we're going to get started. So today, Dr. Shalini Boggarapu is presenting training rounds. So for the third-year medical students, to complete the program, every pediatric resident presents a grand round. And so today, Dr. Boggarapu is going to be talking about tuberculosis. And then I want to make a couple of quick announcements. We've got every resident and faculty should have two forms to fill out. One is the comment form for Dr. Bocchini for the farewell dinner. The other one is for faculty. Faculty vote for the outstanding graduate and intern. The residents vote for outstanding teaching faculty, graduating resident and intern. So be sure, Jessica's going to come back with the ballots for the outstanding faculty and residents so that she can mark you off the list so that no one can just take their form and stuff the ballots, and so that it's all anonymous. Instead of just putting them on the table. So Jessica will be back for you to turn those in after grand rounds, and then wait till after Dr. Boggarapu is finished to write on your forms, talk about the comments for the residents. All right, and I'm Dr. Red, so I'm going to have to watch the video.
Okay, Dr. Cooper. Thanks, Dr. Cooper.
All right, guys, so I'm going to talk about TB today. With a show of hands, how many of you feel comfortable diagnosing TB, whether it's something you learned in third year of med school or as an intern or resident, without calling our pediatrics infectious disease people? Anyone? Okay, how many of you feel comfortable starting a patient on treatment for TB without, calling one of our ID guys? So that's why I picked tuberculosis, because though it's becoming less and less common in the United States, we still see it. I've seen 3 kids that had to go under treatment during my 3 years of residency so far. And every time it happened, I had to open up Redbook, call infectious diseases, and I felt like I was never comfortable. And if you're going out into your own practice, you might not necessarily be able to call an infectious disease specialist and just say, what should I do? When should I see them back? So basically, the objectives of my grand rounds are just to talk about how they might present and why diagnosis is difficult in the pediatric age group, and just a few basics about treatment. So let's get started. This handsome fellow is Robert Koch. He discovered the bacillus, Mycobacteria tuberculosis, and he was a Nobel Peace Prize winner. He discovered TB in 1882, and he also did significant work with anthrax and cholera. So he was just really into the bugs. A little bit of the epidemiology. So there's about 9,500 new cases of TB reported in the United States in 2013. And just keep in mind, they don't update the data year to year. They do it about every 2 years, and they update their goals for TB eradication. WHO is part of this. It's kind of a big deal. So the total incidence in the United States is 3 per case, which has declined from 4.2% from the previous years. Basically, the overall decline in incidence in the United States is due to better living condition, better provision of medical care and access to health care, and overall decline in ages less than 15 years, or in our pediatric group, was basically due to less diagnosis in pediatric patients born in the United States. So a majority of the pediatric patients that are diagnosed with TB were either foreign-born or had parents that were foreign-born, and obviously some of the travel history that we look for. Basically, it's more common in the age of less than 5 years, and then in young adults. It favors the age groups between 5 to 14. They have the lowest rate of infection out of all the age groups. And I think we still do a lot of work here because there's new patterns in migration, people being displaced by war or natural disaster, so we have to keep that in mind. So the way your incidence goes up is when you have an infected small subset of population that are gone undiagnosed and they're spreading it in the community. Basically in the US, children are infected by someone close to them in their home, but outbreaks can occur in schools, nurseries, churches, just basically riding the school bus or any organized sporting event. So something to keep in mind. So just reiterating what I said earlier, this chart shows you the number of TB cases in US-born patients versus foreign-born patients. In the 90s, early 90s, and I don't have the statistics in the 80s, but it's definitely a lot higher in US-born patients versus foreign-born patients, especially with the spike of HIV in the 80s. As you can see, the number of TB cases in foreign-born person kind of stays around the same, but there's a huge decline in the number of cases in the US-born patients. So, and then this is the obligatory map from WHO showing some of the numbers. So these are countries that have reported at least one case of extensively drug-resistant tuberculosis by the end of 2012, and that means resistant to more than 2 drugs. So not just isoniazid and pyrazinamide, but also probably ethambutol and some of the uncommon drugs that are used to treat TB, which is pretty dangerous. And this is the number of multi-drug resistant TB, and that means multi-drugs resistance is more than one, so isoniazid and pyrazinamide are the more common ones. As you can see, the United States has the lowest number of multi-drug resistance, but it's still present here. And then this map shows you all the cases that are recorded electronically, basically EHR, or there's some kind of reporting system that keeps track of all the TB patients in the community, and this data is shared with certain organizations so they can keep track of the outbreaks and where the numbers are going. And the darker green colors are the ones that are doing a good job of it, and as you can see, it's usually all the developed countries are included in the dark green color, so we're keeping a pretty good track of where the cases are and how they're being treated. So I think that's a good thing. Some of the risk factors for obtaining TB, basically for, children get it from adults. High-risk adults are those adults that inject drugs, they're homeless, history of stay in correctional facilities or nursing homes or shelters, or your patients that have lived abroad for more than 2 months in a known endemic area and can give you history of known exposure with to a patient that has TB or was diagnosed with TB. Adoption, interestingly, is a risk factor, and especially in the last 20 years with the rate of international adoptions going up and it becoming a little bit more common. There's a rise in the number of cases of TB in adopted individuals, and there's actually a few studies that are being done right now to kind of figure out the numbers and how to handle this. And HIV in itself is a risk factor for TB. And then a risk factor is having latent tuberculosis, which can progress to tuberculosis, and that's common in certain risk groups in pediatric population. So who are the patients that go from a latent infection to active TB? These are infants that are less than 4 years, especially if you're under 2 years of age, you're at the highest risk factor. And then the young adults, so you have that gap between 4 to 14 where you're kind of protected. It's not as common to get infected. And if your skin test converted in the past 1-2 years, if you've gone to having a negative PPD and then all of a sudden you have a positive PPD, for the next 2 years, you're at higher risk of developing active tuberculosis, which is kind of interesting. And immunocompromised patients, for obvious reasons, are at higher risk than the general population. So a little bit about the pathogenesis. So Mycobacterium tuberculosis is a rod-shaped bacteria, and this is like an electron microscopy picture, and this is a gram stain. And there's 5 type of bacteria in this class. M. tuberculosis is the one that's known to cause significant amount of human disease. We don't really see any GI tuberculosis due to the bovis strain as much anymore because we pasteurize our milk. These are some of the other 3 strains that don't really cause significant human disease. So basically, how do you get an infection? From inhaling droplet nuclei that contain the mycobacteria, and you form a primary complex. The primary complex consists of your site of infection where the mycobacteria are resting in your alveoli, and then your draining lymph nodes that are draining that area. And the mycobacteria will get carried from that alveoli to the draining lymph node, and they kind of stay in your lymph node. And this together is the primary complex. In the alveoli, the bacilli multiply. Most of them actually get killed. It's actually really hard for these bacilli to cause significant disease. Our body does a pretty good job of getting rid of them and preventing it from going into an active infection. So why do patients get tuberculosis? This is basically an interaction between the bacilli and the host. So the bacilli, there's certain areas where the strains do better than other areas. So the endemic areas, the strains tend to be stronger and they tend to multiply more easily. And also the number of bacilli that are inhaled and how many of them multiply and make it out of the alveolus also plays a factor in those who get active TB. And then host factors such as, if they're immunocompromised, if they're malnourished, if it's one of our patients that's failure to thrive, they're at higher risk of getting TB, or TB might be causing their failure to thrive. So just a few things to keep in mind. These bacilli are obligate aerobes, and they actually grow pretty slow. And they cannot grow when the pH is lower than 6.5, which is why every time if you bronch somebody and they have like a caseating granuloma and you get out samples, you don't find any bacilli because they do not survive in that pH. They tend to stay outside the granuloma and in the surrounding areas. And they're lower in number there, so it takes a lot before this TB leaves your lung and causes disease elsewhere because they die in the center of the granuloma. The disease is actually caused by our response to the bacilli trying to kill it. And I don't go into too much detail because I'm sure you guys went through that in second year. So just to remember, the destructive tissue hypersensitivity is part of the host response, the immune response, and the alveolar macrophages just play a very important role, and that's where our basic pathology in this disease comes from, which is the caseating granuloma. So there's 2 areas that we have to consider in the primary complex, the lung and the lymph node. So the area of the lung that's infected, basically once the bacilli goes into the alveolus and sits there, it's going to multiply over the next 2 to 12 weeks. And in this time, our body recognizes it and starts responding to it. The tissue hypersensitivity develops and it can heal, and that results in fibrosis or calcification that we can find on x-rays, or it can continue to grow and cause pneumonitis or pleuritis. And in patients that are immunocompromised or just basically can't fight off the bacillus, you can get the caseating granulomatous reaction, where the parenchyma is pretty much it liquefies and you have like a cavitary lesion that you can see on x-ray, and that's kind of right here. Like you can see that's pretty impressive. It looks like somebody took a bite out of it. So the lymph nodes, they tend to heal. They don't suffer as much as the lung does. So, but the problem with that is that means the bacillus is surviving in the lymph node. In fact, you can get reactivation TB from bacillus that's been sitting in somebody's lymph node for 10 years, which I thought was pretty interesting. But sometimes the lymph node can enlarge and cause partial to complete obstruction. The hilar and paratracheal nodes are usually involved in the primary complex. More commonly, the hilar nodes. Partial obstruction by the hilar nodes can lead to partial obstruction of the bronchus, which can hyperinflate the lungs distal to that segment, and complete obstruction can cause atelectasis. So that's why our radiologists like to say TB can look like anything on an x-ray. You can have lobar pneumonia, atelectasis, cavitary lesions, just calcified spots. So it's actually not that easy to diagnose on chest x-ray. And one other thing that the lymph nodes do, and this is more in the endemic areas, especially if your paratracheal nodes or submandibular nodes are involved, they can become caseous nodes and kind of enlarge, and then when they heal, they can form sinus tracts. And this is actually a pretty common complication in the pediatric age group in developing countries, in countries where it's endemic. So, who gets TB? Is every case of TB infective? Definitely not, because a lot of people go for long periods of time without being diagnosed, and not everyone around them gets tuberculosis. So we know transmission is by infected droplet nuclei. It's actually rare to get infected from touching somebody's secretions or touching the towel that they used where the secretions have landed. And also, children are less likely to be your source. Basically, you know, what I said earlier about it being more common in age group 5 years and younger. Well, what do we know about that age group? They don't cough very well, which is why they get sick and tend to, you know, not handle their upper respiratory tract infections as well as adults. So they don't have that force that's required to move the bacilli from the alveolus out up into the environment where somebody else can inhale it. So that's good. So children generally don't spread it to other children or adults. Secondly, children tend to have less number of bacilli in their secretions. Studies have been done to show this, which is why they're less likely to infect people, because one of the factors in being an infective source is the number of bacilli you're discharging every time you cough and let it out into the environment. So just a couple of things. Unless a child has a cavitary lesion or a large upper lobe infiltrate that's pretty impressive, they should generally be not infective to those around them. They are the ones that are the victims. They get infected from the adults around them. So some interesting facts about TB. They're pretty slow growers, the bacilli. They take about 12 to 24 hours just a cycle generation time. It takes up to 6 weeks, 3 to 6 weeks to isolate them from sputum or other clinical specimens using standard culturing methods. And then on top of that, the drug susceptibility takes 4 weeks or longer. So in areas that they don't have advanced techniques, you really need to use your clinical judgment to decide if you're going to start somebody on treatment. So what are the different types of TB? There's primary, secondary, extrapulmonary, and disseminated. We'll talk about primary TB. So this is active pulmonary tuberculosis. Secondary TB is reactivation or reinfection. This is less common in the pediatric age group. This is kind of where latent TB comes in. Latent TB is when you have that bacilli in your alveolus, but you never develop active disease, so there's no clinical signs or symptoms, there's no cough, no fever, and no radiological findings. So these patients basically carry the bacilli, and they don't even have a positive PPD, so you just never know that they have it. But you know, years later, maybe 10, 20 years later, these patients end up becoming PPD positive and having clinical disease. So this is reactivation of the dormant TB that's been in their body. And it is very uncommon in peds patients, so we won't really talk about it today. And then you have the extrapulmonary source where the bacilli are seated in other parts of the body, and then disseminated disease, which basically means you're involving more than 2 of your organ systems. And that's actually more common in pediatric group than adults, and immunocompetent pediatric age group than adults. So these are some of the extrapulmonary sites. So basically, like I said, from the primary complex, the bacilli will be carried in the bloodstream and through the lymphatics to these various areas in the body. They can basically seed anywhere in your body, from your skin, your brain, kidneys, bones and joints, heart, spleen. But some of the favored sites are the apex of your lungs, your kidneys, and your brain, and your bone, because of the high oxygen tension in these regions. So it favors their growth, so they like to go to these areas. So why do kids get disseminated TB? Basically, they have too much of a burden of the bacilli, and they can't respond to it, and they can't contain the infection. So these bacilli are pretty much free to grow and go wherever they want in the body. A lot of times what happens is you'll have these foci in different parts of your body and different organs, and then they remain clinically insignificant, so you don't really know the child has a foci in their liver or their kidney. And so, like I said, disseminated TB occurs in 25 to 35% of children, whereas it only occurs in 10% of adults. And these are immunocompetent population. So let's talk about diagnosis. So a lot of research says that we can't standardize diagnosis of tuberculosis in the pediatric age group, and I never knew why. So we have the Montoux test, or the PPD, which we're all required to take when we start working here. And then we have interferon gamma release assays. QuantiFERON is the one we've heard of before and we use pretty commonly in practice. And then there's the T-SPOT test. So these gamma assays, they're both blood tests. They're actually really great when it comes to the adult population. They are not so great when it comes to the pediatric population, and there are several reasons of that. But first, let's talk about the PPD test really quickly. It's where you inject 0.1 cc's of the purified protein derivative, and then your T cells will react with it. Now, if you've been infected or exposed to TB or have the bacillus in your body and your body recognizes it, these T cells go to the skin and they release the lymphokines, and that's when you get your induration, which is measured within 48 to 72 hours. Sometimes you can actually have positive results when the induration occurs after that 72-hour period, so just something to keep in mind. With the PPD, you can have a lot of false negatives, especially in the pediatric age group. Because of the very young age, they are naturally immune immature, and malnutrition can have an effect on it. And then if the patient has a viral infection or was recently on steroids, the PPD is not very reliable. And then other reasons is lots of user error. Poor technique and poor reading of results by healthcare providers can be a factor too. And then you can also have a lot of false positives because of the cross reaction between the mycobacteria tuberculosis and the non-tuberculous mycobacteria, or if a patient's been previously vaccinated with BCG, especially if they've received more than 1 to 2 doses, and especially if they've been vaccinated in the last couple of years, they can have a false positive. And also reading the Montoux varies between different regions. So if you're in an endemic region, a smaller millimeter of induration would be positive, as opposed to if you were to read the test in the US. A little bit about the blood tests. There's 2 of them, like I said. What these tests do, they measure the interferon gamma produced by the T cells in our body. The reason these tests are really great is because they're very specific. So they only measure the response to Mycobacterium tuberculosis, not the other strains. So you don't have to worry about cross-reactivity, and it reduces the large number of the false positives. QuantiFERON measures the interferon gamma that is produced by all the cells in your body, whereas the T-SPOT measures the interferon gamma produced just by your lymphocytes. And this is just a one encounter test. They don't have to come back to read anything. You draw their blood, and then you just wait for the results. and it is not affected by previous vaccination, so it's actually pretty accurate. Unfortunately, there's very, very limited data on the results in the age group of less than 5 years, and that's also the highest risk age group for TB. So we can't necessarily use a negative QuantiFERON to say that a child doesn't have TB. This is when you have to use your clinical picture and your history of exposure. So as far as the PPD, an induration greater than 5 millimeters in children that are known to have a close contact with a diagnosed or a suspected case. This is going to be positive, especially if they have X-ray findings of active or of previous TB, if they have clinical evidence of TB, so poor weight gain, or if you have a child that's been between the 20th to 30th percentile of the growth chart and all of a sudden they're falling. And it's going to be positive without any of these in immunocompromised children or children on steroids or children that have been under transplants. An induration greater than 10 is positive in if these children are at risk of disseminated disease. So anyone under the age of 4, if the induration is greater than or equal to 10, it's positive. Any children with chronic medical conditions like diabetes, renal failure, lymphomas, you should consider anything greater than 10 positive. And the induration of greater than 15 positive in any child over 4 years without any risk factor. So these are the recommendations by AAP in the Red Book. So who gets tested and when do you test them? Immediate testing is done in children and neonates with a contact with confirmed or suspected contagious disease, somebody with active cough, active symptoms, neonates and children that have X-ray evidence and clinical findings, and then immigrant children from endemic areas, and we kind of see that pretty often in Shreveport actually, especially in the last couple of years. I feel like we've had several patients on the floor that have migrated here, so just something to keep in mind. And children with travel history, and remember they have to have stayed in an endemic area more than 2 months. Annual testing should be done in children with HIV. Some clinicians recommend twice a year actually, because of the indolent nature of the disease, especially in these immunocompromised patients, and missing it can result in drastic complications. And children that go to jail, we have to test them every year. And then patients who are at risk of progressing from latent tuberculosis to active disease should be checked often. And these are children that have diabetes or chronic kidney disease or any congenital or acquired immunodeficiencies. They should be tested. Or patients with history of recent exposure, but we don't know if the exposure was positive or not. And then obviously you need to test every patient before you start immunosuppressive therapy. So all the patients we get that we start on the pulse steroids and do all that, we usually do a PPD on the floor and wait till it comes back before initiating treatment. So just a little bit about the sputum samples. Unfortunately, younger children cannot provide you with samples. They're not going to cough into a cup. And so what we have to do is induce samples from these kids. So what they do is they use a jet nebulizer, kind of break up the secretions, and then we do a little CPT to have them kind of cough it up like we do in our cystic patients, and then we do nasopharyngeal suctioning. It's actually pretty effective, and you can use these samples for both culture and smear. It's very useful in neonates. In fact, this is the only way you can get a sample, only way you can do it without being pretty invasive in neonates. So when we had a patient on the floor, we did gastric aspirates. You have to get 3 consecutive morning samples. This is so that when the patient wakes up, they don't start moving around and peristalsis doesn't go into effect and move their secretion. So overnight, they've basically been swallowing everything that they've been producing. So in the morning, you can kind of suck it up and use it for culture. But you cannot use it for a smear, so that's the only drawback. And even under optimal conditions, these cultures are only positive in about less than 50%. So diagnosis is pretty difficult in a child. It's actually very easy to miss this because of these tests and because TB can look like anything, especially in children. So with that said, a negative culture does not rule out disease. Negative culture with a positive skin test or blood test and a history of contact, or if you have radiological findings, or if a patient just has a chronic cough, just hasn't been feeling well and you can't find any other reason, you should really consider TB and really think about whether you're going to treat them or not. And in patients that have a known contact but you can't get samples from, you can get records of the known contact and see what their drug sensitivity was, and you can pretty much tailor treatment for your patient even if you can't get samples. The most important thing is to treat them and not wait for your samples. So primary pulmonary disease occurs in less than 50% have clinical symptoms. Usually they have cough, which is non-productive, and dyspnea, and sometimes they have fever and night sweats. I have not seen this textbook case except when I worked in India, so just something to keep in mind. You know, if they say they're not having night sweats, don't rule it out. A child's not going to go wake up their parent and say, I'm sweating. It might have happened and you just don't know it. But something to really keep in mind, anorexia and decreased activity. So these failure to thrive children, this should be a part of your basic workup. And then some patients will have pulmonary symptoms like cough and wheezing, decreased breath sounds on exam, and then x-ray findings, and we'll go through that in a second. And then progressive primary pulmonary disease is basically when the bacilli just go to town in the alveoli. They do really well there, and they cause a liquefaction change around the alveoli. And these patients will have pretty significant clinical findings, these progressive patients. They'll have the fevers, the significant weight loss, and they present within a protracted time period. But they can still have full recovery with appropriate diagnosis and treatment. So a little bit of the x-rays. So I don't know if you guys can see this really well, but this is a little calcification of a healed area of the primary focus. So it's pretty subtle, but this is a 7mm calcified granuloma that you can see. So this is what it can look like. And also calcification means the disease has been there anywhere from 6 to 12 months. It's just something to keep in mind. So you have to worry about who they've infected in that time period if they're adults. And then here you can see hyperinflation and prominent left hilar adenopathy. So right there. And then there's hyperinflation in the distal segment. And then you have alveolar consolidation in the upper part of the left lobe and lower part of the left lower lobe, or upper part of the left lower lobe. So there's one way to see it. And then this is taken on a patient with just a history of cough. It basically shows right hilar adenopathy and paratracheal node enlargement, and then just some changes in the right middle and lower lung fields. This was a primary pulmonary tuberculosis case in Philadelphia. So TB really can look like anything. So any positive radiological findings in a patient that you suspect has TB should pretty much be your diagnostic criteria. And you can use that to treat patients. And then another chest x-ray. This is an infant with miliary tuberculosis. This is what it looks like. And we've seen x-rays that look like this that weren't TB, so just something else to keep in mind. So reactivation TB, like I said, it's more common in adults. It's rare in children, especially if the infection occurs at less than two years of age. And it's a more localized indolent course where they just kind of have fever on and off, and they usually respond well to treatment. Disseminated TB, like we talked about, spreads through the lymphatics and the blood vessels to distant sites, and the number of organisms really plays a factor in how the disease turns out. And miliary disease is the most common subset of disseminated disease in the pediatric population. So clinical features of the disseminated disease, you have fever, anorexia, weight loss, you can have lymphadenopathy, hepatosplenomegaly, or you can just have severe lung involvement without presentation of your other organ systems. And pediatric patients tend to seed in their brain and their abdomen more than adults do. So look for signs of meningitis and peritonitis. And sometimes meningitis in these patients just presents as a chronic headaches that come and go. And they just kind of feel bad and they kind of have loss of appetite, but that's it. So this should definitely be your differential diagnosis for fever of unknown origin, especially if you can't really find the source. And the other thing, a lot of these patients, they'll come in with these complaints, you do the x-ray and you see either a lobar pneumonia or pneumonitis, and then you treat them with antibiotics and then they feel better. This actually happened to my continuity patient. I diagnosed him with pneumonia and we sent him home with antibiotics. Mom came back and said, oh, he stopped coughing, he feels better. So he probably had some kind of viral or bacterial infection superimposed on the TB, but he still continued to have fever, and then he fell from his growth chart. So that's when we decided to work him up for TB, but I will admit it took us a long time before we got to that point, and I think that's something, you know, we should be aware of. So he basically fell from 30th percentile to below 5th percentile by the time we caught it. So, and all he had was a little runny nose, and Mom couldn't even tell me that he had a fever. So just something to keep in mind. Central nervous system involvement is the most serious complication in children. These metastatic lesions tend to release small number of bacilli around your brain into the subarachnoid space, and this can lead to inflammation and gelatinous exudate that kind of hangs around in parts of your brain, and you can only imagine this can cause a lot of complications. First of all, it can cause inflammation of the vessels that are right in that area because your body's reacting. That can lead to strokes and infarcts, so just something that can happen with that, and can also lead to hydrocephalus, a communicating hydrocephalus. So CNS complications are pretty wide in range. So these are the 3 stages of your central nervous system involvement. The first stage basically is 1 to 2 weeks, and you just have non-specific symptoms like that. Headaches I was talking about, kind of not feeling well, and then in the younger, less than 2 years of age group, look for loss of milestones. And the second stage, this occurs after the 2-week period, and it can kind of happen suddenly where they just feel tired, and this is when parents bring their kids to the hospital, and they can have nuchal rigidity and positive Carnegie and Brzezinski sign. They can have seizures and hypertonia, and at this point they do have hydrocephalus. And some of these patients can present with signs and symptoms of encephalitis, so changes in their behavior, kind of altered sensorium, so something to think about. And then the third stage, which is what you don't want your patient to get to, is pretty serious. They can go into a coma, hemi or paraplegic. This is where their vital signs start deteriorating. It's hard to control them even with treatment, supportive treatment. They can get hypertensive, and you have the decerebrate posturing, and eventually they can die. Even with the initiation of treatment in this stage, you might be too late. So with that said, the prognosis correlates with where you catch them in these stages. The earlier, the better. And if you catch them in the third stage, they can survive, but they'll usually have some sequelae of blindness, deafness, CP, that kind of stuff. In these patients, a CT and MRI is very useful to see for the hydrocephalus, the edema, the vasculitis. You can see enhancement in the basilar regions of the brain. Scrofula. I thought that was kind of cool, scrofula. So this is when your lymph nodes are involved, and this is very common in the pediatric age group. So kids, they present with your lung infection, or they can present with your lymph node infection, or with the meningitis. So these are some of the more common ways pediatric age groups present. So this is the most common form of the extrapulmonary TB. It can involve any of the draining nodes depending on your site of infection. Initially, the draining node will get enlarged, but it's still non-tender, kind of firm, but not hard on palpation. And then this node will start draining to the surrounding nodes, so then you have multiple nodes in the area involved, and then they kind of attach together and they become a matted mass of nodes. And that's your classic clinical picture of lymph node involvement in TB. Most of the time they're unilateral unless they have lymphatic spread to the other side, then they can be bilateral. And you can, most of the time you don't have any systemic signs or symptoms. This is just an incidental finding in these patients. And they respond well to treatment. You can do a fine needle aspiration to guide diagnosis. Sometimes you have to do an excisional biopsy, but they recommend not doing any surgery without initiating treatment in these patients. Gastrointestinal disease can kind of vary, but I picked out just a couple of things to talk about. So peritonitis is what we would worry about. It can occur in the miliary or the disseminated form. And you have two forms of the peritonitis, generalized or localized. The localized occurs due to direct extension of the infection from the lymph node and that part of your abdominal cavity that's infected. And you can kind of get abdominal pain, maybe a little tenderness, anorexia can occur. And in generalized, these signs are more prominent. Patient just doesn't want to eat, they just don't feel good. And then eventually they can have ascites. And in the localized infection, sometimes you can feel a mass. So, and I think that's more common in endemic areas, something to keep in mind. So pericardial disease, very rare. The pericarditis can be a result of direct invasion of the bacilli from the lung tissue or from lymphatic drainage in this, of the nodes that are around your heart. And then rarely you can hear a pericardial friction rub or a distant heart sound. And latent tuberculosis, as I mentioned earlier, it's where you inhale the infected droplets, you have a reactive skin test, but you have no clinical symptoms, no radiological findings. And infants with latent TB, 40% will progress to TB. And then as they get older, the risk of progression to active disease becomes less. So a special population to just mention quickly, HIV patients. It's really sad because having HIV is bad enough, but the incidence of TB and HIV kind of go hand in hand, and WHO has a couple of really good maps for those of you that are interested. This is more common in developing countries. HIV-infected children have 30 times the higher rate of TB infection than a non-HIV infected patient. Diagnosis is very difficult to obtain, especially because these patients are immunocompromised, and the disease is also at the same time more severe and progressive in these patients. Drug resistance is higher, and they have an increased mortality rate. And having TB causes your HIV to kind of flare. The virus will replicate at a much higher rate, and this is what kills these patients. Not the TB, but the fact that the HIV just kind of goes uncontrolled because they have TB. And these patients also, just something interesting, their blood tests are negative too. The QuantiFERON, the gamma release assays are negative in these patients. So it's HIV specialists, they are really careful about TB. They tend to test their patients pretty frequently because even with negative testing, they could possibly have disease. So it's something to keep a close follow-up on. And a quick mention for neonatal tuberculosis, it usually presents like sepsis. You really can't tell the difference between GBS sepsis and tuberculous sepsis. The neonate will usually end up having a poor response to a full treatment of antibiotics, or even after day 4, if they're still really sick, something just to keep in the back of your mind. And at this point, the only thing that's really going to help you even consider TB is going to talk to the mom. Getting a family history and maternal history of possible exposure is what really should drive you to diagnose this patient and start them on treatment, especially because their skin test isn't going to be positive until 2 months of age usually, and you can tap these patients. CSF is usually negative, and studies have been done, and they basically show that you need large amounts of CSF in order to find something. So just something I thought that was interesting. Just quickly about treatment, usually children are treated very similar to adults, and since adults are your infective source, a lot of recommendations say that you should use the same drug sensitivity of the adult to tailor your medications for your children. So 6 months of total treatment in just your basic primary pulmonary TB. The first phase should be with 4 drugs. So 2 months of 4 drugs, and then continued by 4 months of just isoniazid and rifampin. And this is nearly 100% effective, and a lot of studies have been done, and statistically this is the best treatment. And in endemic areas, directly observed therapy is recommended. So that's where you do the twice a week or 3 times a week treatment. And they have these TB centers. I actually worked at one, and the patients, they have their scheduled appointments, and they come in, and you have all the medicines divided up into little bags, and then you give it to them, and they have to take it right there in front of you. And this is actually really a good way of doing it in certain areas. So for extrapulmonary TB, these patients, again, they're very subtle in their presentation because the number of bacilli are actually small because a lot of them get killed in the alveoli. But they still have the disease, and the burden is less, so you still have to treat them, but you just treat them for 6 months. But special consideration should be if they have disseminated TB or bone is involved. It's hard to get rid of it from your bone because of the high oxygenation there. And at that point, you should treat anywhere from 9 to 12 months, depending on your patient. HIV patients generally need 9 to 12 months of treatment. Usually they'll do the 2 months of the 4 drugs, and then some clinicians will follow it with 6 months of the 2 drugs, or continue it for 6 months after their specimens are negative, for the bacillus. And unfortunately, not only is it difficult to diagnose TB in HIV patients, it's difficult to treat TB in HIV patients. A lot of the medicines you have to use for HIV interact with your TB medicines. Rifampin can go up to toxic levels with the protease inhibitors that the HIV patient's on, and it can reduce the efficacy of the protease inhibitors to be on the TB meds. So something interesting to think about. And these are some of the recommended doses, and these actually go across the board for children and adults. And they're similar by WHO, and Red Book recommends the same dosage. Just quick mention about the vaccine. It's the only available vaccine, BCG. The schedule varies depending on where you live. Most places do 1 dose, but endemic areas with high risk do 2 doses. So the original vaccine was formed from the Mycobacterium bovis strain, and it was subcultured every 3 weeks for 13 years. So once they started subculturing it, they started sending it to other labs that continued to subculture it. So it kind of was a pretty big effort to make this vaccine. But because there's so many subcultures, each vaccine is different depending on which culture it grew from. So we can't really tell if it's working or not. I mean, it still helps. There's numbers that back it up, but this is why you have such a varied response to the vaccine. And it differs widely depending on where you got the vaccine because of the characteristics of the strain. And the other reason there's variation in the efficacy of the vaccine is administration. It's an intradermal injection. It's the best way to give it at an estimated dose, but again, if this isn't done right, then your vaccine's not going to be effective. So basically all the studies that have been done were combined to come up with a common number, and these show that this vaccine prevented TB in about 50% of high-risk cases. And it prevented 50 to 80% of disseminated disease and meningeal TB. So the takeaway message is it's really good to prevent the complicated tuberculosis disease, which is what children are at higher risk for. So you should definitely vaccinate children in endemic areas, and then in the United States, if there's any cause for concern such as migration population or family history of TB. WHO basically recommends 1 dose, but some countries follow it up with a 2nd dose a year later. Who gets it? All the infants with a negative skin test but are in constant exposure to somebody at home, which is an adult with persistent pulmonary TB, an adult ineffectively treated or incompletely treated, and persons with drug-resistant bacilli. If they're in the home, then the child should immediately be started on treatment. And this was interesting because my patient that we ended up diagnosing with TB, mom, when we asked her questions about her treatment, she couldn't tell me if she took it for 4 months or 2 months, and you know, that's what causes it to kind of stay in your body, and it spreads to the rest of your family. And some of the reactions to the vaccine, skin ulceration, osteitis, fever, a little loss of appetite. Rarely you get the systemic complications, which are convulsions, irritability. And even if you get all these reactions, it doesn't affect the potency of the vaccine. So this is my end. This is a vintage poster that they used to put out in the 80s. It's in the United States National Library of Medicine. So it's kind of geeky, but so this basically is my message. You know, TB can look like nothing. Your child can look completely normal and still have it, like this muscly man. Any questions? Yes, Dr. Koo.
That was very nice. Can you elaborate on the management of the contacts that are demonstrated to be positive, different ages, different background?
Basically, contacts will be if they're, so when you have a patient that you've diagnosed with TB, you need to test everybody in the household. And this can be with the PPD, and you need to get the sputum samples. Especially if you know you have adults in the home that can give you samples, so you can send them off for drug sensitivity testing. And treatment's pretty much the same for adults and children. So WHO recommends the same guidelines for children as far as the duration of therapy, which drugs you use. And this doesn't apply to the areas that have multiple or extensive resistance. But these are your basic drugs that you use for children and adults, and this is from the neonatal period to adulthood. So you test everybody in the household and do chest x-rays. And then based on those results, you treat everyone.
If they're asymptomatic, they still get 6 months of this combination?
If they're asymptomatic, but they have a positive PPD, and then you have a known case, you have to treat them. If they're asymptomatic, but have a x-ray that's positive, but a negative skin test, you have to treat them. So they're not very strict on who gets treated, as long as you have history of a known contact. That is the key thing here, especially for our age group that we see. You know, they might not show anything, but if you know that there is a contact with positive disease where they've been tested, where they've been treated, you definitely have to treat them. But yes, if they come in and they're clinically asymptomatic, but if they have a positive PPD and there's somebody else in the family that we just diagnosed, you have to treat them. Or if they even have a negative PPD and negative blood test, but they have radiological findings, you do have to treat them. So, yes. Yes,
That was
Doctor.
excellent, Shalini.
Thank you.
And one other point I would like to make regarding the side effects of the drugs.
Yes.
Did you talk about the side effects of
Yes,
the
I can. I actually have those. I just felt like we were getting really long, so I didn't want to.
The point I wanted to make is
Yes,
that rifampicin is a microsomal enzyme inducer.
Yes.
So that can decrease the action of oral contraceptives.
Yes.
That is something to bear in mind when you start the treatment in teenagers.
Yes.
And also steroids, same with the
Yes.
increase in steroids.
Yes.
It decreases the action of steroids.
Yes. And that was mentioned in a lot of places, actually. So. That's it. Any other questions, comments? Okay, thanks, guys.